Welcome to our presentation today. My name is Jane Houston and I'm the Clinical Director of Midwifery and Women's Health at Frontier Nursing University. I'm so very honoured to welcome my colleague today, Barbara A. Anderson, Doctor of Public Health, Certified Nurse Midwife, and Fellow of the American College of Nurse Midwives and Fellow of the American Association of Nursing. Barbara Anderson is a Professor Emerita and former Director of the Postmasters DNP program at Frontier Nursing University. She co-authored the 2nd, 3rd, 4th, and 5th in-process edition of Caring for the Vulnerable, Perspectives in Nursing Theory, Practice and Research with Dr. Mary DeChesney. The 3rd edition won an American Journal of Nursing Book of the Year award in 2012. She's lead editor for Best Practices in Midwifery, Using the Evidence to Implement Change, an American Journal of Nursing Book of the Year, and lead editor of the 2nd edition in 2017. She's also the lead editor of DNP Capstone Projects, Exemplars of Excellence in Practice 2015. She is a public health specialist and nurse midwife with academic practice and consultation experience in the US and globally. It is my pleasure to introduce Dr. Barbara A. Anderson. Thank you so much.
Hello, I'm so glad to be talking with you today, and it's a privilege to be able to give this presentation for Frontier Nursing University. The name of this presentation is Vulnerable Populations and Health Justice, the Role of the DNP Prepared Nurse. And I would like to share some ideas that I've had with you in the last 10 years about DNP prepared nurses and where we're going in this country with this new degree. The objectives for this presentation are 3. First, I'm going to talk about health justice. Health justice as the basis for DNP prepared nurses caring for vulnerable populations. And this is a unique focus that the DNP programs have, that this is a unique focus of the curriculum, health justice. Secondly, I'm going to discuss and review the outcomes as we know them now that are demonstrating how DNP prepared nurses are promoting health and social justice across the nation. And third is I will discuss the role of the DNP prepared nurse in authoring and in public education in care of vulnerable populations. Now, all of these will tie together during the presentation. First of all, I'd like to make a few comments about the American health paradox. We are a country of enormous national wealth. In fact, we have the highest per capita income, or close to it at this point, of any nation in the world. But conversely, the paradox is that we have high levels of poverty and high levels of illness. We are the most expensive healthcare system in the world, and it is a fragmented healthcare system. And unfortunately, we have the worst health outcomes of any developed nation. Now, I want to be really clear that what I'm talking about is developed nations. There are 193 nations in the world. 60 of them meet the economic criteria of being described as developed. We, of course, are one of those nations. Our health outcomes rank 60 out of 60. In other words, we are at the bottom of health outcomes for any developed nation. And the interesting corollary to this, and this is one of the paradoxes, is that we are the only developed nation, again, 60 out of 60, without a universal health care system. This information is from the National Research Council and the Institute of Medicine. Now, this health paradox that we have creates a lot of health injustice. We know the U.S. has the worst outcomes on the following measures, and these apply a great deal to midwifery. We have the worst outcomes with birth, with injuries, with homicide, adolescent pregnancy, sexually transmitted infections, HIV/AIDS, drugs and alcohol mortality, obesity, diabetes, heart disease, chronic lung disease, and disability among older persons. Again, this is among developed countries. These outcomes hold across age. They also hold across ethnicity and socioeconomic levels, so they are not only the problems of the poor. And this is something that is very much misunderstood. These problems are not just among the poor. They are grounded in pervasive injustice, pervasive issues of social injustice which affect access and adequacy of care for many low-income, middle-income people across the nation. Now, what is health justice? An interesting question, and I would like to present some information from the American University Law Review. And this is their definition of health justice, and it is a term that is being used a lot in the literature these days. It is a judicial and legislative framework that scaffolds the safety net, protecting the health of the public, including the most vulnerable. Health justice fails when a nation does not address the social determinants that create inequity and injustice. And that's what we're going to talk about in relation to the DNP. Inequity, injustice, health justice, and the DNP. How does this all fit together? A social determinant of injustice. Now notice I said injustice, not justice. A social determinant of injustice is the U.S. nursing shortage. It is a key threat to the stability and the resilience of the healthcare system. Our healthcare system cannot exist in the absence of adequate nurse staffing. The RN workforce shortfall is regionalized in our country. It is most acute in rural areas. It is also acute in the southern part of the nation and in the western regions of the nation. Other areas have much better access to RNs than these three areas. And in addition, there is a critical need for advanced practice and doctoral level nursing leadership. We need to be at the table. We need to be being drivers in social justice for this nation. The DNP Innovation. Now, the beauty of it is that this is a response to health injustice. The landmark report, The Future of Nursing, Leading Change, Advancing Health, calls for doubling the number of doctoral prepared nurses by 2020. This is Institute of Medicine, Robert Wood Johnson, 2010 landmark report. And the DNP curriculum across the nation has addressed vulnerability within the framework of social justice. So these key words, DNP, vulnerability, and social justice, are the essence of what the DNP degree is about. DNPs are expected to enter the workplace thinking differently about practice. And this is something to keep in mind, this idea of thinking differently about practice. So what do we know? What do we know about what's happened with the DNP, health justice, and vulnerability? To improve access toward health justice, the Future of Nursing Campaign for Action has been implemented. This was in response to the 2010 Institute of Medicine recommendations. It is a joint initiative with the Institute of Medicine, the Robert Wood Johnson, and the American Association of Retired Persons, who have been very supportive to the idea of the DNP. So we have some definite strategic action going on. What else do we know? We know that across the nation, there is lots of DNP educational activity. In fact, it's rather overwhelming when we think about what's happened in only a few short years. Currently, there are 303 DNP programs in all 50 states and in the District of Columbia. There are plans for an additional 124 programs. That will be over 400 programs. Currently, as of the latest figures of 2016, the number of students, DNP students enrolled was 25,289. That's a lot of nurses. And the graduation rates in 2016, 3,294 DNPs graduated, an increase of 13% above the graduation level and rate of 2015. By 2017, 4,855 DNPs graduated, 15% above the rate in 2015. All of this is from the American Association of Colleges of Nursing. Now, a lot of facts and figures here, mainly demonstrating that there's a lot of DNP educational activity occurring across the nation. What do we know? We know, first of all, that we don't know much. We have minimal outcome data. We have a lot of facts and figures about who's going to school and how many are graduating, but what do we know about the outcome? National nursing education efforts across the nation with the DNP have been focused on defining and developing the curriculum, defining and developing the DNP academic offering. That's where the efforts have been, and that's fair enough. That's where you have to start. But there have been no large-scale evaluation studies of outcomes among DNP graduates. Yes, there have been small anecdotal ones. Yes, there have been outcomes published by universities, but there is nothing on the national level that says of these 303 programs, 25,000 students, 4,000 graduated last year, what's happening? The data is anecdotal, with very minimal data on impact of how the DNP prepared nurse is having any influence on patient care or on systems outcomes. Now, that's not necessarily bad. The degree is new, but it's to point out that to date, we cannot prove that this makes a difference. So what do we know? Publications are focused on DNP innovation. This explains the DNP program development. Much of what has been published in the literature is about the development of the curriculum. It is written mostly, and this is interesting, mostly by non-DNP prepared educators. And why is that? Because we haven't had DNP educators. We've had PhD and DrPH and EDD level educators, nurses who have been able to prepare DNP, but they themselves are not DNP. So most of the literature is written by non-DNP prepared educators. The literature primarily describes the profile of the DNP graduate. This is what the DNP graduate looks like. And it discusses the satisfaction of DNP graduates with their education. None of that tells us if the degree is effective. It simply gives us a process measure of what a DNP graduate is like. What else do we know at this point in time? Well, we know that the healthcare environment is changing. It's rapidly in flux. The Affordable Care Act is implemented. The Affordable Care is challenged. The national health care structure remains highly uncertain. The discussion on universal health care continues. There's poor health status among Americans, but this continues to escalate. Now, I'd like to just point our attention for a minute to the canary in the mine. When we look at, and remember that old term, the canary in the mine, the thing that gave the warning sign, the canary in the mine in the U.S. is rising maternal mortality, with the U.S. having the highest death rate of mothers in any developed country, again 60 out of 60. Many of the transitional countries and some developed countries are providing better care in terms of outcomes than we have. The sad thing that we've seen recently has been that Texas is now leading the nation with maternal mortality. And it's not just leading the nation with maternal mortality, it is also leading the developed world. Texas has the highest rate of maternal death of any place in the developed world. So what do we know? The healthcare environment is highly unstable. That brings us to the critical question. And the critical question is the DNP innovation making a difference in healthcare outcomes? Is it making a difference in health justice? What do we know? We don't. We do not know how the DNP is affecting the health care of Americans. But we do have some information, and here is some new information that has come out in the last few years about the DNP. What are we finding out? First of all, we're finding out that DNPs are moving into academic teaching roles. Now, at first, that was somewhat like, well, that's not what the DNP was about. The DNP is supposed to be in the clinical area. But let me propose this thinking. By having DNPs moving into academic teaching roles, we are having people in academic teaching roles with strong clinical focus, usually with current clinical focus, people that really know what they're doing in the clinical area. Now, I've been a nursing administrator for over 15 years, and one of the biggest problems that I had as an administrator was getting adequate, clinically prepared faculty to teach students. One of the really good things about having DNPs move into the academic teaching roles is they bring their strong clinical focus to the arena of healthcare. In addition, we're also finding out that DNPs are moving into clinical leadership. And this is exactly what the purpose of the DNP is. The purpose of the DNP is to improve the health care and health justice for vulnerable populations, and DNPs being up front and center with a doctoral degree behind their name are in a strong position for clinical leadership. And this is something that particularly makes me happy. DNPs are writing. Now, they are telling their stories. Now, that's anecdotal, but it's still their stories, and that's great. They're describing their impact in healthcare. Again, most of it's anecdotal. Most of it's a one-site information. It's not the national data we need, but it is the beginning of looking at their impact of their degree. To date, DNP graduates have authored 690 publications, and that is since the inception of the degree, and first graduates that came out in the about 2005. The DNP authorship has particularly focused on two areas, and this is where I think it's really showing that it's doing what it's supposed to do. It's focusing on clinical practice, and it's focusing on vulnerable populations. So let me say that again. The DNP authorship is increasing tremendously, and it is focusing on clinical practice and on vulnerable populations. In the current book that I am editing, which will be out next year, The Caring for the Vulnerable, the 5th edition, we have solicited 13 DNP writers for this issue of the journal, of this issue of the book, specifically targeting getting the clinical expertise and now the doctoral level skills of the DNP. What else is new? Well, we are finding out the DNPs are entering the workplace, thinking differently about practice. They have a different perspective. They have a perspective of justice, of health justice, of vulnerability. And this is because this is specifically built into the curriculum. But we need to have hard data on this. This is our observational data. It is not hard data. So is the DNP making a difference? That's the big question. So I would like to propose a clarion call to get the evidence. We need evidence about outcomes with DNPs. First of all, we need their stories, and they are beginning to tell their stories. This is retrospective data. This is what happened in the past. This was my experience. Much of it's anecdotal. That's good. But it doesn't give us hard data. The second area of data is impact on practice and systems. That's cross-sectional data. This is what's happening right now on our practice. This is what's happening right now on our healthcare systems. We also need and very much need to begin secular and national trends, longitudinal data. Over time, what are we seeing with the change in practice? Or are we seeing a change in practice? Are we seeing a movement toward health justice? Are we seeing a movement toward increased attention to vulnerability? We need systematic reviews. We need collaborative research across universities and healthcare systems. And that means that universities need to work with each other. And I call upon our universities that have DNP programs to collaborate together on looking at the outcomes of their DNP graduates. Not just what they're doing, but whether it's making a difference. And we need to work with our healthcare systems, not just the universities, but also with the healthcare systems, and gather information about the impact. We need to ask the question, who is impacted by DNP care? Is the DNP tied to an increase in social justice? Can we show that there is indeed a link? Can we show that there is a link in the care of vulnerability? At this point, no, we cannot show that. But that is my clarion call with this presentation, to say that time has come, the time is now. We need to start gathering the data on the impact that the DNP is having on our people, on our healthcare systems, and on the vulnerability of our large number of population that are at very high health risk. I have a few references that I have included in this presentation. They are only just a few key references. I have many more. If you would like to ask any questions, or you would like to be in touch about this presentation or this issue, I would be happy to talk to you. You can reach me at my Frontier Nursing University email, barbara.anderson@frontier.edu. Thank you very much, and I appreciate the privilege of speaking with you today.